Alright, so we went quickly through anatomy and physiology. We talked about electrophysiology. I'll review it again with y'all next week, once you've had a week for it to kind of sink in and all that. But now we need to move forward. We need to get on into what we are looking at, what we are doing. Because next week we'll get through what we can of cardiac monitoring. Next week we will really get into some EKG interpretation. All right. So ECG monitoring. ECG monitoring. Graphic representation of the electrical activity of the heart. A cardiac monitor can tell you several things. Yes. It's in the module. A cardiac monitor can tell you several things. It can tell you heart rate. It can show you how good the electrical system looks in the heart. There you go, one idea. It can show you what the electrical activity of the atria looks like, ventricles. We can do 12 lead where we can get several different looks. We can do lots of things with it, but what we cannot do is get a representation of the mechanical function of the heart. An ECG monitor is solely for the monitoring of the electrical function. We cannot get a representation of the mechanical function. Now, there are tools that can tell folks in the healthcare field, stroke volume, cardiac output, things like that. You can do an echocardiogram. You can have different things like a Swan-Ganz monitor or a Swan-Ganz catheter put in, things like that. None of which we have access to in the field, right? But we can do a couple of things to determine how well the mechanical function of the heart is working. How? EKG is going to be electrical function, that's what I was just saying. Vital signs, check the pulse. See how I do that pulse? Look at their skin color. Look at their presentation. Look at their mental status. Treat the patient on the machine. Your assessment, your physical assessment where you put your hands on the patient, that's going to tell you the mechanical. Your visual assessment of that patient, looking at that patient, that's going to tell you the mechanical function. Because if the heart is not pumping well, several things are going to happen. They're not going to have good neurostatus, right? Because the brain's not getting oxygen. Their skin color is going to be pale, pallid, because they're not getting blood pumped to their periphery, right? Their pulses may be weak, right? Several things that you can identify that way. But right now we're going to talk about electrical function. Your ECG is an important diagnostic tool, but your most important diagnostic tool is your assessment of that patient, of what you're seeing with your patient. I have a saying that I say a lot and that you'll hear other folks say a lot. And it's not 100% true, but it holds pretty steady, and that's treat the patient and not the monitor. We're treating the patient, not a machine. That machine, though, is going to give us very important information to help us aid in the treatment of that patient. It is a diagnostic tool. It is a tool. But it does not take the place of our assessment. It just helps. So ECG monitoring, it helps identify cardiac abnormalities, heart rates and rhythms. Abnormal conduction pathways, hypertrophy or atrophy of portions of the heart. What does hypertrophy mean? Yep. Somebody who pumps iron all the time and is just all buff like me, they're gonna start getting hypertrophy of the pecs and the biceps and all that, right? Why? Because they're working those muscles out and they're putting resistance against them and they're getting bigger and bigger, right? A heart that's overworked, a heart that's meeting resistance working, it's going to hypertrophy too, but that ain't good. That ain't good. What is atrophy? It's the opposite of hypertrophy. Alright? If you don't use it, you lose it. And it can also help you with identifying ischemia and infarction. Okay? Can it tell us pumping action, cardiac output, blood pressure, or cardiac muscle hypertrophy? Well, if you got a Zoll or a Life Pack that does blood pressure, yeah, it can tell you blood pressure once you take it, but it cannot tell you pumping action, cardiac output, things like that. Does that make sense? Does that make sense? It can tell you heart rate, rhythm, impulse conduction, abnormal pathway, so on and so forth. The evaluation of an ECG requires a systematic approach. You analyze the ECG, then you relate it to the clinical assessment of the patient. What? That's what I just said just a minute ago. At the end of the day, you use your ECG as a tool to help you with your clinical assessment. It's only a reflection of the electrical activity of the heart. Okay? The electrical basis of the EKG. So, I had this big long spiel about the history of the EKG, and I'll give you a little bit of it. The history of the EKG started with some frogs. Back in 1790, this dude named Luigi Galvani decided to cut a frog in half and hook up its lower half, its legs, to some like a copper pole, and then he had zinc on it. Anyways, he provided electrical stimulation to the frog's legs to show that the cells depolarize with electricity. All right. Back in 1790, if we would have been sitting in here, and one of us was like, "Hey, I can make this dead cut in half frog dance," we'd all been like, witchcraft, whatever, right? Back in 1790, that was weird. Bringing a dead frog back to life was shocking and ghastly supernatural feat. Fast forward a little bit. 1855, a couple guys named Kulliker and Mueller. They also used a frog leg to help figure out that the heart, its beat, comes from an electrical stimulus. What? Back in 1855, folks didn't realize that the heart came from an electrical stimulus. Going back to what I said about 4 hours ago, most of your community around doesn't really fully understand what's happening with the heart. Anyways, these guys found that when a motor nerve to a frog's leg was laid over an isolated beating heart, its isolated beating heart, the leg kicked with each heartbeat. Remember that conductivity, that all or nothing phenomenon? Remember when I mentioned for like 2 seconds that a lot of this propagation stuff that we're talking about also applies to skeletal muscle as well? So that's what was happening there. So they showed that, hey, we've got a beating heart. We're going to lay this exposed nerve of the frog's leg over this beating heart. Now, I don't know how they hooked it all up and all that. I just know what the book says. And then they figured out that the electrical stimulus that causes the frog's leg to kick must cause the heart to beat as well. Thus, an association between the rhythmic pumping of the heart and the electrical phenomena was scientifically established. That's a very, very simple, basic eureka point, but that was kind of like the turning point. Back in 1855, that's when we started moving towards this. Then in 1880, there was these couple of guys named Ludwig and Waller. They used this thing called a capillary electrometer, where they discovered that the heart's rhythmic electrical stimuli could be monitored from a person's skin. This consisted of sensor electrodes that were placed on a man's skin and connected to a Lippmann capillary electrometer, which used a capillary tube and electric field to detect faint electrical activity. That may not seem like a lot, and it really doesn't matter here nor there, but I think it's pretty cool that they actually were looking through a tube, seeing the electrical stimuli based off of the skin. Weird. Then you get into the turn of the century, the start of modern EKG monitoring. This is where this German dude named Dr. Willem Einthoven comes in. We're going to talk a good bit about old Einthoven, because he had this triangle that we're going to learn about. Dr. Willem Einthoven, a brilliant scientist, suspended a silver wire between the poles of a magnet. Then two skin sensors placed on a man where the connected and then connected to the ends of the silvered wire, which ran between the two poles of the magnet. That's important, the two poles there. Each time the heart beat, that wire that was in between those two poles would twitch because of the electrical stimulus. Then he took a light and cut a hole, and it's kind of hard to see here. He took a light and cut a hole in that magnet. He had the silver wire in between the two poles. He had the leads hooked up to the patient. Then he put the EKG recording paper, very rudimentary, very elementary, just a very, 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 basic EKG monitor. Each time the patient's heartbeat, that silver wire would twitch. The light going through the poles of the magnet would actually burn onto the paper, and it would give you a very tracing. I don't know if that's the word, I'm certain time. At that point, that's where they started determining that they could record the EKG. 1901. That's a long time ago. But when I mentioned earlier that in 1855 the folks realized that, hey, the heart beat off electrical stimulus, some of y'all were like, what? They didn't know that. No, we didn't. Modern medical hasn't been around very long. That's why it's called modern. But why is it called, why do we say EKG when it's actually electrocardiogram? Well, a couple things. In America, it would be ECG, but it came from the German language with a K, Kraken. And it's that's why. So it's just kind of one of those traditional things that you got onto. You got the K in it, whatever. Yeah. Well, and it sounds a lot like EEC or whatever, the brain thing. But I digress. All right. So with the electrical basis of the EKG, the electrical activity is sensed on electrodes placed on the skin surface. Y'all know that. You got your salt, pepper, ketchup, whatever's green, grass, whatever, pickle, yeah, sure. All right. The monitor, the machine itself, is recorded to form your ECG. Cardiac monitor depicts electrical impulses on the monitor or oscilloscope. I mentioned earlier Johnny and Roy, the old emergency. Look, I'm telling y'all, go on YouTube and YouTube, it would be emergency with an exclamation mark, or just YouTube Johnny and Roy. Please, go watch it. I love that show. But when you're down in lab, if y'all look up on the when you walk in to the right, the cabinet, we got all the old equipment up there, kind of like we didn't have anywhere else to put it, so we put it up there. Yeah, and it does. The oscilloscope. And the reason why I brought up Johnny Roy is what you'd see just a green complex and it would disappear. And the green complex and it would disappear. Nothing like what we got these days. So they would have to print off a whole strip, then evaluate it. Your electrode is an adhesive pad that contains a conductive gel that attaches to the patient's skin. I mean, at this point, everybody in here has seen an electrode. Correct? Right? Yes? Cool. Alright, if you haven't, there it is right there. So, what do we call them? We call them the leads. We call them the leads, and you've got several different leads. But the leads must have a positive, a negative, and a ground. So that's why you've got salt, pepper, ketchup, and then that fourth lead, it also provides a ground as well. Voltage on your ECG monitoring, voltage may be seen as positive, which is going to be an upward deflection. So when I see a complex and it goes up, huh? Don't think about that right now. No. Right. You can have I know, and let's work it through before you try to do that. And we got 20 minutes. And I'm not going to use all the 20 minutes, but on your strip of paper, may be seen as an upward or a positive deflection, or downward, which is a negative deflection. Alright? And then you've got your isoelectric line. Your isoelectric line is what we call the baseline. Okay. Anything that's deflected upward is a positive. Anything deflected downward is a negative. What does that mean? It doesn't necessarily have anything to do with the depolarization and all that phase stuff that we talked about. It has more to do with the direction in which the electrical current is traveling. Alright? So if it's traveling towards the positive electrode, it's going to show as a positive. And if it's traveling away from the positive electrode, it's going to show a negative complex. Alright? Following me? Seeing this? Cool. Alright? ECG machines offer many views of the electrical activity of the heart. They monitor the voltage changes between the electrodes. Modern ECG views electrical activity of the heart from 12 leads. Some are 15, some are 18 leads. Most of all the standard ones that we use are 12 leads. You've got, now this is going to be important. You've got 3 limb leads, 3 augmented limb leads, and 6 chest leads. I'm mentioning the chest leads, the precordial leads as V1 through V6 right now, just as so you understand that you've got different leads, but we will not actually learn how to interpret anything from V1 through V6 until we get to the 12 lead section. Everything that we're going to learn strip-wise is going to be in a lead 2 view for right now. And we'll see why maybe in a minute. All right? So your ECG rhythm strip, well, let me wait on that. We'll get to that in just a minute. Your ECG graph paper, what I handed out to you guys. All right? Every machine, whether it uses this type of graph paper or whatever, is calibrated the same. All right? It's supposed to leave the machine at a constant speed of 25 millimeters per second. And it is a graph. It is graph paper. On the horizontal line is measured time. All right? So time. On the vertical line is amplitude or voltage. Okay? Very important. Like, understanding how this graph paper without anything on it works will be quintessential for you to understand this graph paper when you get all the squiggly lines on it. Okay? If you look very closely, you got a very small box, very tiny box. Each very small box represents 0.04 seconds. Each very small box represents 0.04 seconds. If you notice, if you find a thick line, and then you go to the right of that thick line, you'll see 1 box, 2 box, 3 box, 4 box, 5 box. Then you get to another thick line. So from left to right, 1 thick box, as far as time goes, represents 0.04 seconds times 5, which gives you 0.20 seconds. So each small box represents how long? 0.04 seconds. Remember, our mind can't really fathom the time in which the heart works. 0.04 seconds is a very, very minute amount of time. Like, we've had a million of 0.04 seconds in the time of the heart. Not a million, but it's a lot. All right? Our mind can't fathom that time. Our mind cannot fathom a 0.20. Like, when you think about it, maybe you can, I can't. But these time values are going to be important. So if I've got 1 small box, that's going to be how long? 0.04. If I've got 1 big box, 0.20. If you take a look at your graph paper, ouch, and you look, I think I tore you off enough. If you look in the white section of your graph paper, you'll see a line. Then a little bit down, you'll see another line. A little bit down, you'll see another line. So in between that line and the next line is 3 seconds. Y'all see what I'm talking about? The white part of your, on the top of this, very, very small straight line right there. And from that line to that line, about 3 seconds. Alright? So, if you have graph paper that have those lines marking that, you need to always at least have a 6-second strip. Alright? If you do not have graph paper that has that line that marks the 3 second, then how many, if I've got a box that represents 0.20, how many of those big boxes do I need to put together to make 1 second? 5, right? So 5 small or 5 big boxes makes 1 second. Right, 10 makes 2, 15, makes 3 seconds, right? So you can count 1, 2, 3, 4, 5, 6, 7, 8, 9, all the way to 30, and that would give you 6 seconds. Okay? Good. All right. So your squares measure the length of time it takes for the electrical impulse to pass through the specific part of the heart. I want y'all to memorize these time values here. You've got to, because when we get to the arrhythmias, we may be looking at a first degree heart block. First degree heart block is going to be a PRI that is greater than 0.20 seconds. We need to be able to quickly identify the time. Okay? I promise you guys, if y'all will not get overwhelmed tonight, study this stuff, come back next week, study it again, come back next week, study it again, you'll get it, okay? I promise. You cannot put an unrealistic expectation on yourself to walk out of this door after having 3 or 4 hours, 5 hours of this lecture to be experts at it. That is an unrealistic expectation. Okay? Don't walk out of here defeated. Don't walk out of here discouraged. Because if I were sitting in your place, and I have been sitting in your place, I was defeated and discouraged. And it screwed me up. Okay?
So little square 0.04, big square 0.2.
Right.
And 5.2 is a second, 15 is
So that will be.
That's right.
0.2.
So only 5 of them. Now, they say it's just under the normal science rhythm, you need at least time.
I don't know. I've never heard that. I mean, that's not anything I'll teach them here. You gotta have it lead.
Interpret it at least 10.
You gotta have a 6 second stir. 6 seconds. Alright. Amplitude is measured on the vertical axis. So, here's what I'm going to throw this out to you. Amplitude is something kind of important, but I can look at a contraction and say, hey, that was a pretty strong contraction. I had a pretty high amplitude. We're not going to measure amplitude whenever we're doing this rhythm interpretation. Each small square is worth 0.1 millivolt. Each large square, that's going to be your big square, your 0.20 that's horizontal. It's going to be worth 0.5 millivolts vertical. Okay? Okay. Let's we will pick up